Hi, this is Dr. Bernstein with your July 2017 teleseminar. Before we begin, I want to give you my usual warning that the answers I give to your questions may be way off. The answers are intended to be educational for the group as a whole. I have not gotten a physical exam or complete medical history of each questioner, so it's very hard to be able to give you an answer that's pertinent to an individual situation. But whatever answer I give may be generally educational, and that's the purpose of this series. Our special subject for today is going to be the effects of dietary protein on body weight. The reason I bring up this subject is because a number of the questions, both this month and in prior months, advocate the elimination of protein for the purpose of reducing insulin requirements and losing weight. This is obese people start cutting out protein. Big mistake. I think I've gone into this before, but I cannot overemphasize the importance of maintaining protein nutrition. Every individual needs a minimum amount of protein to survive. You need protein for your muscles, protein for your organs, etc. Even for hormones, cannot survive without an adequate amount of protein. I've seen people come in here who were boasting that they were on ketogenic diets where they were eating a lot of fat to keep their blood sugars down, and they had wasted away and they were generally in poor health. If you want to lose weight, you cut down the carbohydrate. Carbohydrate has a much greater, well, we know that insulin is a anabolic hormone. It builds both fat and muscle. It requires carbohydrate in order to build fat, requires protein in order to build muscle. If you reduce the carbohydrate, the insulin will be unable to build fat. But if you reduce the protein, you'll be unable to maintain your muscle mass, and that's potentially dangerous. So in order to lose weight, you cut the carbohydrate. The fat in your diet has relatively little effect on body fat because dietary fat has very little effect on insulin requirements. Whether you're a non-diabetic and make your own insulin, or whether you're a type 1 diabetic who injects insulin, the amount of fat you eat has a minimal effect on how much insulin your body needs. But the amount of carbohydrate you eat has a tremendous effect on the amount of insulin your body needs. And insulin, as I said, can build fat. If you want to lose weight, you cut the carbohydrate. If you want to gain weight, in theory, you could add carbohydrate, but the trouble is that you will have a much bigger effect on blood sugar if you add carbohydrate than if you add than if you add protein. And the dietary protein's effect on blood sugar, the timing of the protein, more likely matches the timing of injected regular insulin to cover the meal. So if you want to gain weight, you increase your dietary protein, cover it with regular insulin at mealtime, and that is the technique that I usually use. Now, we'll begin with our questions. Concerned that when I weigh my protein, I'm getting inconsistent weights depending on the water and the fat in the protein. Well, this is potentially a problem. There's also a problem if you're having chicken with bones or steak with bones or whatnot, what I recommend is that for consistency, you either weigh cooked or uncooked, and do the same thing every time you weigh the protein. You won't be exact, but at least you'll be approximately right. And if there are bones, you remove the bones before you weigh the protein. That's about all I could think of. How many minutes or hours after a Humalog injection will that injection cover any carbs? For most people in most situations, I don't recommend Humalog to cover dietary carbs because Humalog is so potent. 1 unit of Humalog will lower my blood sugar by 120 milligrams per deciliter. So there's no way I can use it to get precise dosing. Someone who's grossly overweight, on the other hand, will be very resistant to the effects of Humalog and might be able to do fine-tuned dosing of carbohydrate. But there's still another problem. If you're on a low-carbohydrate diet, and meaning your meals are mostly protein, the Humalog works too fast for the meal. And you'll initially go too low, and then later on, and you'll have to take glucose to cover the low blood sugar. Later on, you'll start going up as the protein part of the meal gets digested, and you'll have to, somewhere along the line, take extra insulin. So it doesn't really work. Sometimes I'll use Humalog to cover a mixed meal if I'm eating out. Well, I shouldn't even say that. That was 10 years ago. Nowadays, I never use Humalog to cover any meals, and I don't recommend that for you. Use regular insulin because the timing will more likely match a low-carbohydrate diet. People who eat high-carb diets and take Humalog never have anything approaching normal blood sugars. And if you want to survive diabetes long-term, normal blood sugars is the name of the game. Will someone with prednisone diabetes remain diabetic when their doctor finally takes them off prednisone? Very good question. It really depends upon how long you're on the prednisone, because usually doctors who put people on prednisone do nothing to control their blood sugars. And if you're walking around week after week, month after month with high blood sugars, this is toxic to beta cells, and you're going to be destroying beta cells. So eventually the diabetes will become permanent. But if you precisely normalize blood sugars while the patient is taking prednisone, you could prevent that from happening. Now, how long can you be on prednisone without developing permanent diabetes? I don't know. I've not seen such a case, because any cases that have come my way, I've controlled their blood sugars. I would guess that 1 or 2 weeks, if your blood sugars don't go above 150, maybe 1 or 2 weeks of 150 would be safe, but I just don't know. Would be a guess. So I wish I could answer you further. Reread your book on exercise. Still not clear on amount and time of day which is most effective in keeping blood sugar even and relatively low. Well, first of all, the individual who can normalize their blood sugar solely with the help of exercise is extremely rare. And I do not advocate exercise for lowering blood sugar. I advocate diet and medications, but exercise by building muscle can reduce insulin resistance and enable a person to get by with lower doses of medication, and in rare cases, maybe to avoid the need for insulin, but that's extremely rare. The time of day for exercise, especially for type 1 diabetics, would be to avoid the morning hours because of the dawn phenomenon. The liver is destroying insulin at an accelerated rate for the first 3 or 4 hours when you get up in the morning, and you do need a certain amount of insulin in your bloodstream to offset the stress hormones that you make when exercising. So we see a lot of people who exercise in the morning having blood sugars go up. Some people even take rapid-acting insulin, like regular insulin, to cover that blood sugar increase. So by avoiding the morning hours, you can avoid that blood sugar increase. Any suggestions on how to switch from Humalog to regular, as I work different shifts and can't guarantee a scheduled meal break? I'm a member of emergency services. Well, as I mentioned earlier, it's very hard to cover meals with Humalog. This person wants to, finds out he has a break right now, so he's going to eat right now, and he takes Humalog because it works faster than regular and is more likely to prevent a blood sugar increase. I guess he's stuck with a problem. Ordinarily, you would require twice as much regular insulin as you would of Humalog. So you might start with a trial of 1.5 times as much, and if that's not enough, work your way up to twice as much. My son is 8 years old with type 1 diabetes. His ketones are 0. Oh God. This father is measuring blood ketones. One morning he skipped breakfast and had normal blood sugars, and his ketones were 4.6. At what level can ketones be dangerous for an active 8-year-old boy? You shouldn't be looking at ketones. You should be looking at blood sugars. It's interesting that you didn't mention his hemoglobin A1C. Again, like many endocrinologists, you're not paying attention to blood sugar and only looking at ketones when you should be looking at blood sugars, and if the blood sugars are normal, not looking at all at ketones. I haven't tested my urine ketones I guess in 50 years, because now that I can measure my blood sugars, I don't go into ketoacidosis. I don't have sky-high blood sugars. So forget the ketones, throw away the ketone meter, and keep his blood sugars normal. If, on the other hand, you're following the ADA diet and his blood sugar goes up to 500 or 300, then you're going to have to check for ketones because he may develop ketoacidosis. I'm using Truvia to sweeten coffee, tea, etc. Each packet contains 3 grams of erythritol, which you say will raise blood sugar. Other sites say it passes through body undigested and doesn't raise blood sugar. Which is correct? Erythritol will raise blood sugar about 1/10 as much as pure glucose. So one packet with 3 grams would have 3/10 of a gram. If 1 gram raises you by, say, 6, this would raise you 3/10 of 6, so that would be 1.8 milligrams per deciliter. Do you still recommend 30 grams of carbo daily for someone like myself who is a type 1 with ileostomy due to ulcerative colitis and meals flow through my pouch within 4 to 6 hours? I don't know why the amount of carbohydrate that you have in a day has anything to do with your ileostomy. I would say that you read my book, Diabetes Solution, and I don't talk about 30 grams in a day. I talk about how much at each meal. And I would keep the same limitation. That's all I can think of. Would you recommend Tresiba insulin for someone who works 2 weeks night and 2 weeks daytime shift? As they say, it makes little difference the time of day when you take it. Well, that's not so. It makes a lot of difference. And the big problem is with the overnight dose, where because of the dawn phenomenon, it may not last the full night or appear to last the full night for type 1 diabetics. I have to take my Tresiba at bedtime and then my morning dose about 6 hours later. So I'm taking 2 doses 6 hours apart. Not 1 dose a day and not 1 dose every 12 hours. Now, if your shifts change, you're probably wise to do the same thing. Take, when you're going to sleep, you take a dose and you take another dose 6 hours later. I have to wake myself up to do that. Well, I usually get up to pee in the middle of the night, and that's when I take the second dose. But you may have to set an alarm to do that. Is it true that for type 2s that the GLP-1s can regenerate beta cells? This person is talking about GLP-1 agonists, oral medications that increase serum GLP-1 level. And there have been claims, or I should say isolated studies, for a number of substances, oral agents that are being given to diabetics to the effect that they cause beta cell regeneration. This study showed that DPP-4 antagonists did this. Studies show that Avandia did this. Studies show that Actos did this. There may be a study that shows that GLP-1 agonist does this. However, I've never seen this effect demonstrated to my satisfaction, although I've used most of these agents in the treatment of patients. If there is any beta cell regeneration, it's so small as to be of questionable value. And there's also the possibility that merely by normalizing blood sugar, you're fostering beta cell regeneration. And that was demonstrated with the use of insulin about 30 years ago. But it required maintenance of normal blood sugars around the clock. Your thoughts on the Medtronic, now almost artificial pancreas with continuous glucose monitor that controls the basal insulin infusion? The only time I can see any reason for adjusting basal insulin infusion would be because of the dawn phenomenon. Now, you could set an infusion so that for the last 3 hours of your sleep, or 2 hours before you wake up, and for the first few hours after you wake up, your basal infusion is higher. That's a very nice thing. You don't have to get up in the middle of the night to take a second shot of Tresiba. But that's offset with all the other disadvantages of the insulin pumps, including the incidence of ketoacidosis due to pump failure, which averages between 1 and 2 per person per year, plus the scar tissue that eventually forms at pump sites that gives you totally erratic blood sugars and unpredictability of how much the insulin is going to lower your blood sugar. So there are pros and cons, and to me, the cons outweigh the pros. In a recent study, they reported that blood glucose monitoring for non-insulin using type 2s is not useful in controlling blood sugars. Your thoughts? Well, if you are measuring your blood sugar and don't do anything about it, what's the value in doing it? Well, there was one study that supposedly showed that if type 2 diabetics who were overeating measured their blood sugars, they would reduce the overeating and their blood sugars would improve. So that was one study. And so maybe that's a reason for type 2s to measure blood sugars, just to curtail their overeating. But basically, if you're not going to do anything with the information, there's no sense in checking, aside from that one example. On the other hand, I have all of my type 2s checking blood sugars, and we use the information. They fill out blood sugar data sheets, as indicated in my book, Diabetes Solution. They email the data sheets to me, and we figure out what is happening that's causing anything other than perfect blood sugars around the clock. And it might mean that some medication they're taking has to be changed. It might mean that they've made a change in their diet that was inappropriate. So we do detective work using the blood sugar data to figure out what to do next. Some of these type 2s are getting insulin and may need adjustment. Some of them, I have one type 2 I just spoke to today who only uses oral agents, using several different oral agents, and we have to adjust those. There's a matter of adjusting the timing and the contents of meals. So if you do something with the information, the self-monitoring can be of great value. If you don't do anything with the information, it's not doing anything for you. If you're using one of the newer continuous glucose monitors from Dexcom, they say you can use the readings to adjust your insulin doses and even your correction injections. Do you agree? Absolutely not. And that actually happened to me today. I had a signal on my Dexcom monitor that my blood sugar was low. So I checked my blood sugar. And indeed, it was low. I made a correction with liquid glucose. And I was working with a patient. And about an hour later, I get an alarm again. And it says that my blood sugar is under 60. And I play it safe. I figured, well, it's dropping. I didn't want to disrupt the patient again by doing yet another blood sugar in his presence. So I believed the monitor, and I took, I believe, about 9 grams of glucose, which would have raised me 9 times 8 is 72. And I ended up an hour later, when I finally checked my blood sugar, with a blood sugar of 160. So when I got that alarm, my blood sugar was actually around 90, but it said it was under 60. So before you take any action, correcting a low or correcting a high with a continuous glucose monitor, you absolutely must check your blood sugar. I could have made a similar mistake in the opposite direction and sent my blood sugar to 0. So don't believe this propaganda. When do you do a correction shot of insulin if your blood sugars are too high? At what level would you take a correction dose, and do you use any formula to adjust for onboard insulin? Well, all of this is covered in my book, Diabetes Solution. Those who get under 5 do not add corrections onto corrections. They allow the prior doses of insulin to work before they make another correction. It's playing it safe, and it prevents the wild blood sugar swings that you're going to get if you make a correction on top of a correction. I have one patient who I've been treating now for, I guess, about 15 or 20 years, but she came to me with high A1Cs and frequent severe hypoglycemia, and she was making corrections every few hours. That was the first thing that we stopped, and right away things started settling down. Does the cost of, due to the cost of insulin, do you recommend using human insulins such as Humulin R and N? Well, if you use N, you're going to have to take it more often, possibly using more syringes, and you're going to have a much tougher time getting level blood sugars. The average adult would have to take the N 3 to 4 times a day. R, I certainly recommend. I personally do not use Novolog or Humalog. I use regular for rapid-acting insulin for reasons I've given before. So I strongly urge low carbohydrate diets to reduce your total insulin requirements. Also, I advise not using insulin pumps because of the scar tissue that they create. I've seen pump users cut their dose down to 1/10 of what it previously was, just because they were wasting insulin by injecting it into scar tissue. So don't use pumps and follow a low carbohydrate diet. read my book, Diabetes Solution, which helps keep insulin doses low, because the whole book is based upon the laws of small numbers, which means low carb, low insulin, small changes in blood sugars. What is the longest time you have seen for the honeymoon period by keeping blood sugars in the normal range of 83 to 85 milligrams per deciliter? Well, first of all, I don't think I've had anyone always between 83 and 85, but they're pretty close to that. And I can think of one person who's had lower doses of insulin, therefore honeymoon period, since about 1985. So that would be, I think, 32 years. I'm trying to think if there are others. Yes, there are several others who are no longer patients. They're taking care of themselves. They don't need me. They live far away from me, and they're maintaining their own blood sugars on lower doses of insulin than they would need if there were full type 1s. What do you recommend for fasting holidays like Yom Kippur or Ramadan for a type 1 or type 2 on insulin? Well, again, this is covered in my book, Diabetes Solution. And if you're taking basal and plus meal insulin, you continue the basal and skip the meal insulin while you're fasting. Plain and simple. In counting carbs, does it make a difference if there are simple carbs or complex carbs? Well, I don't advocate counting carbs. It doesn't work. This is guaranteed roller coaster blood sugars, no matter what kind of diabetes you have. And of course, the simple sugars are more destructive than the slow-acting sugars. You better read my book, Diabetes Solution. We have the same amount of carbs from one day to the next. We don't vary it. And the total amount is very limited at each meal. For adults, it would be 6 grams for breakfast, 6 grams for lunch, 6 grams for dinner. And for kids, it could be a half or a quarter that amount. And the carbs are strictly limited to vegetables, not to entertainment carbohydrates like most type 2s are used to, or like the endocrinologists advocate. There's been much talk about type 1s using an HGL2 inhibitor with some great results, especially in reducing the amount of insulin needed. Your comments. I have one patient who's a type 1 who is an overeater, and he finds that he gets better blood sugars when he uses an SGL2 inhibitor. This is the class of drugs that lower the renal threshold for glucose, so that instead of peeing away a lot of blood sugar when your blood sugar is over 165, you might be peeing away when you're over 125. Very effective, but not as predictable as insulin, and there are a number of potential adverse effects. High incidence of urinary tract infection, higher incidence of kidney stones, higher incidence of kidney damage, high incidence of dehydration, sodium depletion, chloride depletion, elevated hematocrit, and possible potassium excess in the blood. So they require the doctor, that is, this class of agents requires the doctor to do a lot of testing to keep the patient safe. So it means probably every month, every 2 months, doing a whole battery of tests to make sure his hematocrit's not too high, platelet count isn't too high, et cetera, et cetera. Yes, also serum viscosity goes up, which can cause glaucoma and other problems. Muscle cramps can increase due to the dehydration. So it's something to stay away from, if at all possible. With your knowledge, where are we with a possible cure for type 1 diabetes? Anything we should be paying special attention to? They're getting closer and closer to biologic solutions to a cure for type 1 diabetes. Getting beta cells to replicate. There are a number of agents that the human body makes that cause beta cells to replicate. And if we could administer these agents, maybe we could restore a normal number of beta cells. And once there are enough, and they might be able to replicate on their own. One big problem is if you've had immune attacks in the past that caused destruction of beta cells, they could happen in the future, but maybe you could give more of this drug that causes replication, and that might reverse the diabetes again. But one way or another, the ultimate solution is going to be a biologic solution, not a mechanical solution, with one possible exception. Unfortunately, very large amounts of money are being devoted to mechanical solutions that are not going to work, where they're asking computer people to devise algorithms for insulin pumps. And the insulin pumps already have problems that doom them to failure, like scar tissue and so on. So it's hopeless in that regard. And it's also hopeless in that doctors are still prescribing high carbohydrate diets and are assuming that if you come up with a cure, a mechanical cure for diabetes, you'll also be able to eat a lot of carbohydrate. And the algorithms for these devices just don't work for high carbohydrate diets because insulin doesn't work fast enough to cover carbohydrate. The mechanical solutions are not going to work. There is one type of mechanical solution that could work, maybe, and that's one where you have very fine micro sensors, so fine that they can go into capillaries and measure actual blood sugar rather than interstitial glucose levels as do the continuous glucose monitors, so that you're measuring instantaneous blood glucose, and the same fibers or similar fibers that go into the capillaries can also release insulin. The trouble is the insulin would have to be super potent. Human undiluted human insulin is very potent. Maybe there's a way, but it seems to me like a biologic solution is the answer. To have something that can go into clinical trials, I would say clinical trials would be 10 to 15 years away. Marketing, maybe 20 years away, maybe 15 years away. Those are all my guesses. I could be totally wrong. Someone might come up with something magical. Diagnosed type 1 last January, age 54. Exercise regularly. Went on the paleo diet and decreased my A1C from 13 down to 6. My doctor thinks it is honeymoon period. Is there any way to tell if this is honeymoon period or due to my changing lifestyle? Well, first of all, although I would advocate a true paleo diet, that is a meal plan that mimicked what our ancient prehistoric ancestors ate, the paleo diets that are being marketed today are high in carbohydrate, they're high in fruit, and you got your A1C down to 6, which is still an average blood sugar of 140, which is almost double normal. So I doubt that you're going to do much better on a regular paleo diet. Suggest that you read my book, Diabetes Solution. Now, in order to tell if you're in the honeymoon period, we want to know, are you making insulin? And the way to find out is to measure your C-peptide level. And if it's anything other than 0, your serum C-peptide, if it's anything other than 0, you're making insulin. And therefore, one can say that you're still in the honeymoon period. Now, what might the C-peptide level be? I don't know. A true type 1 will have a C-peptide level, a full type 1 will have a C-peptide level of 0. Best time to test it is after a big meal, because that will stimulate your beta cells to make more insulin. Whereas if you have the blood drawn when you have a blood sugar of 80, you might not be making any insulin even if you're non-diabetic. So the time to test it is after a meal, not fasting, which is the routine. And that's basically it, serum C-peptide. You recommend the coronary calcium scoring to check for heart disease. My doc tells me this involves taking an ACE inhibitor to slow down the heart and dye injection. Do you feel the dye and ACE inhibitor are safe for type 1 diabetics? Well, your doctor is wrong, or you misunderstood him, because an ACE inhibitor will not slow down the heart. It would be a beta blocker. Now, I had a calcium score done. They did not give me a beta blocker because my resting heart rate is 55 to 60 beats per minute because I'm very athletic. So a beta blocker is not always necessary. It happens that most poorly controlled diabetics have parasympathetic neuropathy and not yet sympathetic neuropathy, so their heart is racing at maybe 80 to 100 beats per minute. They would need a beta blocker. Beta blocker isn't harmful if you take it short term. Long term, there are pros and cons, and it's recommended that you only take it under certain extreme situations. But for short term, no problem. As far as the dye injection, that shouldn't be a problem either, unless you have kidney disease, advanced kidney disease. My main concern is the radiation. And that's why I recommend that if you're going to get a coronary artery calcium score study, you get it done once. You don't repeat it every couple of years because it does give a pretty high dose of radiation. That one dose is not going to kill you or necessarily cause cancer, but if you do it repeatedly or if you have other sources of radiation, you want to keep it down. Diagnosed at 30 years of age with latent autoimmune diabetes, but my family has no diabetes, including my grandparents and great-grandparents. Why do I have this disease? Well, I can only speculate. You might have had a mutation in your genes. You want to learn more about mutations, you watch the X-Men. You might have had viral exposure. People can develop autoimmune diabetes after being exposed to certain viruses. If you watch, if you're Canadian and watch too much of Terrence and Phillip, that might cause LADA. That's about all I could think of. I injected a unit of regular insulin into my deltoid muscle, counted 10 seconds, then withdrew the syringe. As soon as I pulled the needle out of my arm, a big blob of blood squirted out, much larger than 1 unit of insulin I had injected. Should I have assumed, in this case, that none of the 1 unit had gotten into my bloodstream? What would you have done? I would never have left the needle in my deltoid for 10 seconds. That's deliberately causing self-pain and agony. You make any injection should be as fast as possible. Yes, I know the ADA recommends slow injections. I've heard their nurses say no pain, no gain, but that's not what I advocate. You do it fast. And if it hurts, you certainly take it out fast and immediately press on the spot where it hurt. Why? Because if it hurts, you hit some nerves. And the nerves tend to cluster around blood vessels. So if you hit a bunch of nerves surrounding a blood vessel, that blood vessel might bleed. You don't want it bleeding under your skin because it'll leave a lump that will itch you for several weeks. So you press on the site as hard as you can for a minute after the shot. As far as whether you got the 1 unit into you, you have to assume that. You don't guess did you get the insulin in or not, because if you guess wrong, you could kill yourself. 1 unit of regular insulin lowers me by 60. 1 lower unit of Humalog would lower me 120. So I could kill myself if I guessed wrong and injected another unit. Type 1 diabetes. I use Tresiba insulin. Every morning I wake with blood sugars higher than 180 milligrams per deciliter. No matter how much I increase my basal, I have no reason to believe this is my dinner emptying, but firmly believe it is the dawn phenomenon. What do I do? You should read my book, Diabetes Solution, watch my videos, listen to some of the older teleseminars. You have to take Tresiba at bedtime, and then again about 6 hours later, or about 3 or 4 hours before you get up in the morning, if you're getting up 8 hours later. Also, if you're using a pen, you have to beware of the problems associated with pen use, where you can lose a lot of the shot. We've explained how to give proper pen injections in the past. What would your suggestion be to prevent scar tissue from forming when wearing a pump? Can it be worn for many years without scar tissue forming eventually? Can I be more diligent about moving the patch? Well, you could put it on your butt, which has a lot of surface area, a lot of sites, but never sit down. So if you want to stand for the rest of your life, you could put it on your butt. If you have fat arms and don't sleep on one arm like I do, you could put a patch on your fat arms. But for most people, the abdomen and the sides are the only places. And again, you can't even put it on your abdomen if you're going to sleep on your belly like I do. So it's pretty hard. And I really know of no way that you could avoid the scar tissue. I'm a type 2 diabetic. What should be the glucose levels which would define hyperosmolar hyperglycemic state? Would they need to remain consistently above 540 milligrams per deciliter, or just spike above that value while still staying below 300 milligrams per deciliter? Well, I suggest you read my book, Diabetes Solution. If your blood sugars are running this high, you really should read the book. You probably should be on insulin. You certainly should be on a very low carbohydrate diet. This question shouldn't even arise. It turns out that in reality, a brief spike is not going to put you in hyperosmolar coma, which is, for the most part, a severely dehydrated state, which means that you have to be peeing glucose away for a long time in order to get dehydrated enough to have this condition. And if you are above 360 for a prolonged period, that could probably cause a hyperosmolar coma too, because you're going to get very dehydrated. 1 gram of glucose tablet exists. Use Sweet Tarts movie candy. That is true. I do understand, however, that they also contain maltodextrin. I don't know how much. If it's a minuscule amount, like 1/10 of a gram, it's not going to be of any harm. But if it's another 1/2 a gram, then it will later on raise your blood sugar some more. We're trying to find out how much maltodextrin is in them. Thus far, I've not been able to find out. Type 2 using 1,000 milligram metformin in the morning and also at night. Last A1C was 5.9%. Fasting blood sugars 90 to 95 milligrams per deciliter. Should I take the 2,000 milligrams at bedtime? First of all, read my book, Diabetes Solution. And what it'll tell you, first of all, is to follow a low carbohydrate diet, which has more of an effect than the metformin. And 2, it will tell you to switch to glucophage, which is typically twice as potent as the generic metformin. You have been very successful with young children. How do you get an 8-year-old to follow your diet if my son's a picky eater? The most important thing at the starting point is to get the whole family to follow the healthy, low-carbohydrate diet that your son should be following. If you don't do that, you're making it hopeless. Now, if he's a picky eater, there are several sources of low-carb recipes that are delicious. Gourmet meals for little kids. You could look at Type 1 Grit on the internet, where the members of that group are creating and publishing on the internet gourmet recipes for Type 1 diabetics. You could read my book, Diabetes Solution, which has, I think, 100 recipes. You could read my book, Diabetes Diet, which has likewise 100 recipes. And those were created by the mother of a Type 1 child who owns a gourmet restaurant. And those are some of the options. You could also find out what he likes best. It's still not an easy task, but you negotiate with him to try to create meal plans that he will agree to, and give it a try. I just would like to make sure that a ketogenic diet is not bad for my kidneys. Oh, God. The ketogenic diet that most people are talking about is bad for your general health. If you're diabetic, you should be looking at blood sugars, not ketones. And what people are doing is not just cutting back on carbohydrate, but they're cutting back on protein, which is extremely dangerous. And just about every patient who's walked in here on a ketogenic diet where they cut back on the protein were pretty wasted looking and sick looking and miserable in how they felt. So I would get off the ketogenic diet and not worry about the kidneys. It's glucose that causes kidney damage and diabetes. What is the proper procedure for measuring how much 1 gram of glucose raises my blood sugar? Well, there's a whole protocol for this in my book, Diabetes Solution. And if you're type 1, it's very simple. For 100 and, let's see, for a type 1 who weighs about 150 pounds, 1 gram of glucose will raise you by 6 milligrams per deciliter. And then you have to adjust it if your body weight is other than 150. So if it's 300, 1 gram would raise you 3 milligrams per deciliter. If it's 75, 1 gram would raise you 12 milligrams per deciliter. Now, if you're a type 2 and making some insulin, all bets are off. You have to do it by trial and error, because whenever your blood sugar is elevated, you're going to make insulin to bring it down. So you give it a try, maybe using the same guidelines as for a type 1, but you do this on a day when you're not eating all day long. So you check your blood sugar on a rising check it maybe 3 hours later to make sure it's steady. Then you take, let's say, 5 grams of glucose, and you watch your blood sugar for the next, let's say, 3 or 4 hours and see how much it goes up. You might be able to find out in 2 hours, certainly if you don't have gastroparesis. Then this protocol is mentioned in my book. Next teleseminar will be on Wednesday, August 26th. I look forward to meeting with you then. Have a good month.